Did do it? Yeah.
Okay, now we're live. It's April 13th, and this is a continuation of the Senate Health and Welfare Committee meeting. We were together with House Human Services for the first hour, and now we are looking at S-242 and H-353, and we have folks in to testify, so we'll be listening to the testimony. We also have testimony from Office of OPR, Professional Regulation, Lauren Hibbert, and others on our webpage related to the two bills. So what I'm going to ask of each of you folks who are here to testify is that you be concise, complete, and we don't have a lot of time. We have a hard stop at 11:30, so that means there's a maximum for anyone of 7 to 10 minutes. So thank you for your understanding, because we are at the end of the session. So Jeff Hochberg is here from the Vermont Retail Druggist. Jeff, thank you for being here.
Thank you, Madam Chair.
And welcome. And as we're going along, just if you folks could just let us know, yes, you sent testimony in and we have it, or if you haven't done that, we welcome it after the fact. So there we go. For the record.
Thank you, Madam Chair. For the record, my name is Jeff Hochberg, President of Vermont Retail Druggist. I have not submitted written testimony yet, but I will do so today. So I've been asked to speak here on the relation really between H-353 and S-242. And essentially what the committee has before it is yet another example of how insurers and PBMs are creating contractual relationships that restrict both consumers and providers' ability to choose where care comes from. And the insurers and PBMs will argue that this is done for two reasons: safety or cost savings. And safety, from a safety standpoint, the safety concerns to all things healthcare are clearly governed by the licensing boards and the Department of Health. And the reason for cost savings is unfounded because this state already has existing parity framework already established in Vermont statute. And if there is a cost saving measure, again, that would fall under the jurisdiction of the rate regulators and their purview. And we would invite, disclosure into how cost savings can be applied across the system unilaterally. So what H-353 does is it redraws those lines that have been blurred by creative contractual language, and it puts the power back in the hands of the patients and the consumers and the providers that care for them, so that they can dictate and control where their care comes from. So without getting too much into the weeds, I just wanted to remind the committee that the language there around the any willing provider language within H-353 and drawing strict rules to adhere to Vermont Board of Pharmacy rules would accomplish the same goal sought after here in S-242. And with that, I'll really just turn it over to questions and to other testimonies, which I think would help support that conclusion.
Okay, thank you. We've got a question from Senator Hardy.
Thank you, Jeff. Can you just repeat what your last sentence that you just said? Because I think this was the questions we were asking last time.
Right. So what is important in order to achieve the goal of sought after in S-242 is you need to we already have existing framework on parity in terms of reimbursement and provision of care. That needs to be enforced more emphatically, and I think that's where the giving control and some authority to DFR, which was in the original proposal of H-353 and S-238, some of that language back in. But then also expanding the provisions in sections 3 and 4 around patient choice and around adhering to definitions and rules established by the Vermont Boards of Pharmacy around what is and what isn't constitutes an XYZ drug. That is the mechanism by which these contracts circumnavigate the existing statutory framework. And we want to put that back where it belongs, into the proper governing body.
Wait, you just said more than what you just. So now I'm confused again. So are you saying there needs to be additional language inserted into 353 or not?
No.
Okay,
The
and so
language.
353, the way it is, accomplishes what 242 intends to do. So with 353, this way we don't need 242. Is that what you're saying?
Correct.
Okay.
That's exactly what I'm saying. H353, as presented to the committee today, takes care of the issue in S242.
What do you mean as presented to the committee today?
What you have in front of you, what was passed out of the House and came across.
Okay.
Yeah.
All right.
So I just would like to insert here that we may hear a different opinion about section 4 with regard to 242.
Yeah, that's fine. I'm just
Yeah.
trying to be clear about what everybody's opinions are.
Good. And Mr. Hochberg, it would be very helpful to have your testimony in writing so we can sort.
Absolutely.
Terrific. Okay, thank you very much. Any other questions, committee? All right, so we'll move on to Devin Green of VAS. So Devin, thank you for being here.
Thank you, Devin Green from the Vermont Association of Hospitals and Health Systems. And I do have two separate issues that I want to speak to. It's a proposed amendment to the PBM bill, and then it's 242. So I'm going to start with the proposed amendment to the PBM bill and then move into the S242 piece, if that's all right with everyone.
That's fine.
Okay, great. So the proposed amendment, which you can pull up in front of you, is basically responding to what we've seen in the last couple of years from prescription drug manufacturers who have been refusing to follow government programs when it comes to drug pricing, particularly the 340B program. They've just been refusing to follow it. And we've asked the feds for help in this. They have been slow to respond, and so states are responding at this point. So what we have here is taken from a law that passed in Arkansas, basically saying that these prescription drug manufacturers need to honor these state or federal programs and agreements going forward. So that's what we have basically to, again, make sure that the 340B program and any other programs that Vermont or the feds would like to produce to help with prescription drug costs or with stretching scarce resources for healthcare providers, that those programs are honored by drug manufacturers. I do want to point out that this is based on Arkansas law, and the Arkansas law is, there is a lawsuit at the moment, so there is litigation around this. And I don't know the details of that, but I know the Attorney General's office would be happy to speak to it.
Okay.
And so the next issue is.
Oh, wait, we have a question.
Oh, okay.
Devin, this just looking at the language, it doesn't specify 340B. It doesn't say that in there. I mean, I guess we can ask legal counsel, but I'm wondering if this might be too broad. It does say under federal and state law, but I mean, is part of what we're trying to do under 353 is to not have the preferential pricing, more broadly speaking, and this is saying we want the preferential pricing. I mean, anyway, maybe it's a question for Jen, but it seems to muddy the waters a little bit. I don't know if you understand what I'm trying to get at, but.
No, I do understand what you're trying to get at. And I think, I think what we're saying, I think the difference between this and other sort of spread pricing or preferential pricing is to say that the pricing we are trying to protect has been blessed by state or federal government, right? So that is, we want to ensure that those programs are followed by the drug manufacturers instead of just not followed and then people are left high and dry. So I think that's the main difference. This is not controlled by PBMs or other entities. This is controlled by state government, this sort of preferential pricing.
Okay, thanks.
Okay, any other questions before Devin moves to 242? Okay, thank you. Go right ahead.
Great, thanks. So S242 is basically trying to get at this practice called white bagging and brown bagging. And you heard Blue Cross Blue Shield testify to this last week. And I just want to give a little bit of background and definition to what this all means, because it can get kind of tricky. At a baseline, I want to point out that this pertains to specialty drugs, which, as Blue Cross Blue Shield pointed out, they require special handling, special temperature, special authorization, special care. So it's not your typical mail order drugs or typical pharmacy drugs. These are not trying to, this is not putting any limits on the drugs that you can, your normal drugs that you receive in the mail. These are specialty drugs. And the way it works is white bagging is considered when an insurer sends a specialty drug from a pharmacy of its choice to a healthcare provider for the provider to then administer to the patient in the facility. So the facility has no control over the drug. They get it and they administer it there. Brown bagging is when the specialty drug is sent to the patient, and then the patient then brings it into the facility for the facility to administer. Again, lots of concerns here around storage, temperature, and that sort of thing. It does not pertain to home infusions. We're talking about things that are administered it's brought to a facility to be administered. So as you can imagine, the practice of white bagging and brown bagging and sort of severing this link between the healthcare provider and the ability to control the specialty drug does lead to quality and safety, or not, the quality and safety is impaired, basically. So there can be delay in care because the drug was not delivered in time for surgery. There could be incorrect dosage that's supplied. And there could be supply chain integrity issues around storage and delivery. And I think you'll hear more from our next witness about how some of the quality and health outcomes can be impaired by this practice. Because it impairs some of the health outcomes, that can, you will hear from health insurers that this saves money and reduces costs. But again, when you have bad health outcomes due to surgery that needs to be canceled, or something was stored at the wrong temperature, those contribute costs to the system. At the same time, providers are not paid for some of the services that they need to provide around white bagging, such as storage, compounding, or administration of the medications. So again, we would want to ensure that providers get paid for those services instead of passing the cost off elsewhere. So what S242 does is it basically codifies current standards to ensure quality and safety. It's not saying that white bagging and brown bagging are prohibited, that insurers can't do it to try to save money. What it's saying is that there needs to be an agreement between the provider and the insurer needs to basically attests to the fact that it's doing all of the safety and quality measures that it's already supposed to be doing. So you heard from Blue Cross Blue Shield, they're already doing these things. And so we're asking them, we're just asking for that to be codified to ensure that we have all of those safety and quality measures taken care of. And so because I heard what Jeff Hochberg was saying about we don't need this bill, but I will say that we have seen this practice. You're going to hear more from the next witness. We would much appreciate, again, for the safety and health of Vermonters, that this bill codify current practices, ensure that there's agreement between providers and insurers before this practice happens. And I think that would really help in terms of safety and quality for Vermonters. And that's what I have.
Okay, thank you. And thank you. Somebody maybe mute, Devin. How's that work? Yeah, okay. But I'm just gonna say thank you for your clear testimony. The written testimony is very helpful. Thank you. Any questions on the 242 piece? So what I'm hearing you say, just to clarify, is that this actually will improve safety, quality and safety for patients. And it's additive to the section 4 that's in the bill, 353.
Yes.
Okay. Thank you. All right. Other questions?
Well, maybe this is a question for Jen, and just looking at 242, Devin just said that it doesn't outlaw white bagging and brown bagging. But doesn't section B1 on page 2, it says the health insurer shall not, by contract, written policy, et cetera, require that a pharmacy, isn't that brown bagging?
Jennifer Garvey, legislative counsel. So the bill prohibits insurers from requiring brown bagging and white bagging, but it allows insurers to enter into an agreement with the healthcare with providers to do it. So it can't be just the health insurer dictating the brown bagging and white bagging occurs. So it prohibits requiring it, but it allows both parties to agree, the provider and the insurer to agree to use brown bagging.
Okay, that's helpful. That's an important distinction.
Yes.
Thank you. All right, thank you.
Good question.
So,
Senator Hooker.
so how will this intersect with 353 then in section 4? What has to be done to assure that?
I would
Go ahead and ask the question, but I think hold on until,
Okay.
this is a good Jen question,
Yeah,
so we'll go through the bill, but write that down so we don't forget it.
right, and I think you're hearing that from
Yeah.
hopefully hearing that from the witnesses.
Yeah.
Okay.
Okay, so we'll continue with the order that we have. Wes McMillan is here, so Wes, thank you for being with us. And good morning. Why don't you introduce yourself, please, for the record, and then we will listen to your testimony.
Great, thank you. Good morning, I'm Wes McMillan. I'm the Director of Pharmacy at the University of Vermont Medical Center, and I'm also a board member of the Vermont Society of Health System Pharmacists. I have not provided my written testimony to you all yet, but we'll have that to you guys today. I'm here today to offer support to S242 because I believe, as Devin kind of alluded to, that it will improve safety, quality, timeliness, efficiency, and kind of patient-centeredness of medication infusion to Vermonters when those are clinically needed. In our current healthcare model, the provider makes a diagnosis and creates a treatment regimen that's in a shared decision with the patient. Medication can then be ordered in a hospital record or in a provider clinic record for administration to the patient, or the payer may mandate what's referred to as white bagging or brown bagging, as Devin so clearly indicated. So brown bagging, again, is where the medication is either picked up by the patient from the from a pharmacy, a provider designated pharmacy, or it's delivered directly to the patient's home and then transported to the site where the drug will be administered, whether it's provider office or a hospital-based clinic. White bagging is when it's sent directly from that payer designated pharmacy to the hospital or to the clinic provider office where that medication will be administered. So brown bagging is just basically gets into the hands of the patient, whereas white bagging, it goes and stays within the healthcare continuum. So what I want to highlight for you all today are some of the issues, the clinical issues and safety issues with both white and brown bagging and how that kind of integrates in with S242. So for infused medications, the provider will enter a treatment plan into the patient's health record that guides the treatment over a period of time, because oftentimes these are continued medications, either monthly administrations for a really long time, or it could be even more frequent than that. In the setting of payer mandated white and brown bagging, the provider also has to order the medication in a separate functionality. So they'll have to e-prescribe that medication to that payer designated pharmacy. So you have two separate orders, one within the health record and one that's e-prescribed to the pharmacy. So there are the potential for transcription errors when that provider completes that separate prescription. So as an example, the provider may enter a 500 milligram dose of a drug in the treatment protocol, but they may accidentally put in 400 milligrams in the e-prescription. And both doses are appropriate, depending on the patient's indication. So the pharmacist who's receiving that e-prescription may not know that the 500 milligram dose is really what the provider meant, because it's an appropriate dose for that patient. When the patient shows up to receive the therapy, it's realized that the dose is wrong, we don't have enough drug, and then the patient care is delayed. So that's not a frequent event, but it does occur and has occurred. Another issue is the offsite specialty pharmacy dispensing pharmacist may not have all the specific pertinent patient demographic and clinical data to make that informed decision. So understanding it's 400 versus 500 milligram dose, and that could also lead to a medication error. Medication delivery, there are inherent delays. So if you do order a medication from a specialty pharmacy, it's going to take time to get from the location of that specialty pharmacy to either the provider's office or to the hospital-based clinic. So the average turnaround time may be 1, 2, 3, or even longer days to get that into the hands of the provider. So if you need an emergent treatment or urgent treatment, you can expect that that's not going to occur in short order. And because of that, there may be delays in administration, which then the patient could have exacerbation of their illness requiring acute care treatment. As was already talked about earlier, the pedigree of medication is also unknown, as the patient-specific medications are excluded from the Federal Drug Supply Chain and Security Act, or DSCSA regulation. The chain of the custody of the medication cannot be assured. So once that medication leaves the dispensing pharmacy, basically all the regulatory pieces fall apart. So it's out of the hands of the pharmacy, so they're not held from a regulatory standpoint. And once it's in between shipping, there's again no regulatory around the shipping component from a temperature control or other control mechanisms for that product. So when it hits the pharmacy or the provider's office, we really don't know how that product was handled in between. And an issue that's more likely to occur is the medication could be delivered really anywhere within the health system. It could go directly to the provider's office. It could be stuck in a mailroom somewhere, or it could come directly to the hospital pharmacy. For me, that's pretty rare, because if it's a drug that's shipped from a pharmacy to a pharmacy, that could be considered, acting as a wholesaler as opposed to a pharmacy. So shipping directly to a pharmacy within a hospital is pretty infrequent. As an example, I've received several manila envelopes addressed to me personally, and it sits in my office until I actually check my mail. And it's not uncommon that medication is on an ice pack or does not really have any information with respect to storage conditions. And almost 100% of the time, there's no specific temperature tracking logging device within the package. So we really don't have a good mechanism to understand how that product was kept in between leaving the specialty pharmacy and be received at my office here. Again, when we receive the product into the pharmacy or into the provider's office, oftentimes we have to maintain several different medication inventories. One inventory for the medication that the provider is able to buy for their patients, so kind of the in-house buy and bill, if you will. And then a separate inventory for each one of these patients who are required to have payer mandated white bagging or brown bagging. So then you have to keep your inventory physically separated. The inpatient, I should say, the in-house inventory is really patient agnostic. So when the provider orders that medication, it can be administered right away without regard to that patient specific drug coming from a specialty pharmacy. So it's really not easy to discern from day to day in a busy infusion center which patient requires their own medication from a specialty pharmacy versus what is on the shelf and can be used regardless of being patient specific. If the provider discontinues a medication regimen after it has been dispensed from the pharmacy or delivered from the pharmacy, unfortunately the medication has to be wasted. There is no mechanism to redispense that product or use it on another patient because it is a patient-specific product at that point in time. The patient and payer must pay for the medication in advance of the administration. So if it's been discontinued, then that's money out of the system that has to be then disposed of. The patient and the payer basically will not recoup that expense. As an example, some of these medications are very expensive. Infliximab, also known as Remicade, that's commonly used for gastrointestinal or rheumatological diseases, could be anywhere from $2,000 to $4,000 per dose. And so if we have a patient who's discontinued and has to move to a different therapy that's been shipped, then that's $4,000 that goes into the medication waste bin. Similarly, if upon physical examination and clinical review by the provider, the patient needs to have a medication regimen change, a new prescription will have to be sent to the pharmacy, and the patient's therapy will also be delayed. Same day treatment in a white bagging or brown bagging situation is basically impossible. And lastly, the receiving pharmacy or provider clinic will have to redispense an already dispensed medication if that medication requires compounding. So the product that leaves the pharmacy is labeled with how to use the medication, but unfortunately, if it comes as 7 different vials, the provider or the pharmacist will have to compound that into a separate bag and relabel that bag with the appropriate dose and infusion instructions. And there's really not much of a federal or state statute or guidance on redispensing. So it's really a gray zone, a regulatory gray zone, if you will, for pharmacists and provider staff. So in summary, 242, I believe, will meet the needs of patients served in hospitals, infusion clinics, and rural provider offices, and ensure safe, effective, and quality patient care. As was discussed by Devin earlier, this bill will not eliminate white or brown bagging, but it will help the medication supply chain integrity, the chain of custody, the pedigree of the product, and medication storage requirements such as cold chain. That'll all be ensured. And because we'll be maintaining that chain of custody and pedigree, the patient and medication safety will also be ensured for these high cost medications as well. This bill will allow for flexibility for rural providers and patients to choose what's best for them in shared decision making, regardless of where the medication originates. And I believe this bill will also minimize therapy delays and improve patients' access to same-day treatment. So that's all I have for today. I truly appreciate your time and ability to provide testimony.
Thank you. It was pretty comprehensive. And please do send your testimony in writing because there's a lot there and it will take time for us to go through and digest it all. Senator Hardy does have a question for you.
Thank you, thank you, Madam Chair, and thank you, Mr. McMillan, for your testimony. It was very helpful. Two questions, and you covered this in your summary, so, but I just want to make sure that 242 does allow for patient choice, right? So patients can say, this is what's going to work best for me in terms of where to get my medicine, or not. What is your assessment? You mentioned it in your summary, and then I have another question too.
Yep. So this does not specifically, the bill itself does not state that a patient can choose where to receive the medication. It's just really working with a provider on shared decision on where the medication comes from specifically. So whether the patient feels comfortable having this go through their prescription benefit and having it delivered via pharmacy, following kind of the rules, the pieces spelled out within the bill, or if they would rather have that chain of custody maintained within the provider office. So not necessarily stating where, but just how.
Okay. And then my second question is, you know, you're the pharmacist or a pharmacist at UVMMC, correct?
Correct.
Yeah, so it's a big operation. So you did mention small rural hospitals. I'm assuming they don't have as much access. They don't have as big a pharmacy, or maybe even any pharmacy within their hospital. So for them, how would it work for treatment of patients at the smaller facilities?
Yep. So the smaller facilities would have flexibility with this bill to either procure the medication themselves through their normal supply chain means to get that into the hands of the provider, to either compound it themselves if it's a compounded product, or if it's an injectable product that's ready to use, that they would have the ability to get that through their wholesaler. If the medication's an expensive one, which oftentimes these specialty medications are, that could also be done through those specialty pharmacy mechanisms. So going through the patient's prescription insurance and having that sent to the clinic or to the provider's office for administration. So I think to answer your question, Senator Hardy, is that this impacts all Vermont hospitals. We're all dealing with these expensive medication infusions. So Porter Medical Center is a great example. You know, they have issues related to white bagging where they have no control over the supply chain, and oftentimes we'll have to spend time, you know, working with the specialty pharmacy to have those medications delivered in an appropriate manner, so they can hopefully ensure somewhat control of the chain of custody of that product. But like I said, the medications may show up in a manila envelope with really no temperature tracker or any other kind of control mechanism for us to ensure that product is safe to use in our patients.
Okay. Thank you very much. That's very helpful.
Absolutely.
Senator Hooker?
So thank you, Madam Chair, and thank you, Mr. McMillan. So how will this bill ensure that these smaller hospitals don't have those problems? And don't these problems exist even with larger hospitals as far as supply chain and the like?
Yeah, absolutely. And the bill spells out that if the smaller facility would like to maintain white bagging, that they can. It would just be through an agreement with the payer to allow that to continue. I think what this also allows is if that pharmacy would rather maintain control of their supply chain and procure the medication through their wholesaler, that allows them to do that as well. So for me, particularly, I believe this will help provide guidance to the OPR Board of Pharmacy so that they could build some regulation around this for pharmacies, specifically institutional pharmacies. That way, if we have issues with respect to supply chain issues from a white bagging standpoint, that we would have an ability to go to our Board of Pharmacy to help with support. So it allows those rural facilities, you know, choice that they're able to maintain that supply chain in-house, you know, following their normal mechanisms, or if need be because of expense, to still leverage the retail or specialty pharmacies.
Okay, and just as you've heard the questions, perhaps you could add a little bit to your testimony that responds to the questions that you have been asked, that would be helpful.
Will do.
Okay, good. I think we'll move along to Jonathan Heiser, RN at CVM Central Vermont. So thank you for being with us this morning.
No
And,
problem.
I don't think do we have testimony from you? I don't think so. Yeah.
I have not submitted any written testimony.
Okay, and it would be very helpful going forward if you could send that to us, and we'll listen intently to what you have to say. So why don't you introduce yourself for the record, and then we'll be all ears.
Okay, so we certainly will submit the testimony afterward. My name is Jonathan Heiser. I'm a RN at Central Vermont Medical Center. I've been working for the hospital here for 5 years in primary and specialty care practice. Currently work in a multi-specialty office, so we do end up prescribing a lot of these specialty medications that have to go to the insurance designated mail-away pharmacies. I can attest to the fact that this does regularly cause patient delays and safety and quality measures are impaired regularly. I'm here to.
Jonathan, I'm gonna ask if you might get closer to your microphone,
Oh,
because
sorry.
the sound is coming through a little bit blurred. Thank you.
I'm sorry. So I'm here in support of, in favor of S242. I believe it's going to improve patient care and safety. So there are regular issues with these mail-away pharmacies. So it starts immediately after we try prescribing the medication, because we don't have a list of what insurances go to what specialty pharmacies. So it usually starts that we prescribe it to the patient's selected pharmacy, and then they have to decline it and find out what pharmacy it needs to go to as required by the insurance. And then, they'll either tell us to send the prescription there, or it'll have to be sent, transferred over from them to the designated specialty pharmacy. And there are regular transcription errors in that process as well. So I'm here mostly to speak about the patient experience. So with these mail-away pharmacies, a lot of them have very complicated automated answering services. So if a patient tries to contact their office or to get their medication, they have to navigate this labyrinth of these answering services. And then often there's a lot of hold times. We also have a lot of issues with these companies, these pharmacies correctly verifying coverage. So if they try to prescribe the medication and saying it's not covered, then it delays the patient getting the medication. This happens so often, in fact, that even the pharmacist we work with, UVM, has a designated representative for one of these pharmacies, because they have to navigate this every time it comes up. And then, the pharmacy has to reach out to the patient to set up mailing to either our office or to themselves. And that currently is usually up to the patient. We're not asked where we would prefer that to go. So sometimes it just shows up, or the patient calls once they get the medication. And then once the medication is shipped, we encounter new issues with safety and quality. So if the medication is received to the patient or is received by us, we don't receive any tracking of how that medication was handled during the shipping process. So if it was out of temperature range or not, or mishandled in any way, we would have no way of knowing. We regularly have medications delivered to the wrong locations. And sometimes we try to contact these specialty pharmacies, and They just tell us to call around and see if it got delivered somewhere in the area. Luckily, we're able to find it most of the time. But then again, there's no way of us knowing whether or not it was stored or properly. And there's no tracking devices a lot of the times in here to tell us whether or not it was at the correct temperature. So we're ending up having to give or administer patients that could have been mishandled or stored improperly, that could cause harm or just not be as effective to these patients. That's really all I have at this point.
That was a lot. Thank you. And please get us your testimony in writing.
Yeah.
It's really boots on the ground and very helpful.
Yeah.
Senator Hardy.
Thank you, Mr. Heiser. I'm imagining, the FedEx package left on somebody's porch as you're talking about this, and I think we're all experiencing that right now with front porch forum posts about where the heck is my package. But I'm wondering, does your hospital have an in-hospital pharmacy that you use, or do you get your meds from the UVM pharmacy?
So with this insurance designated issue, we don't get that option to use our pharmacy. If we're using the patient's pharmacy benefit, we're forced to send it to these.
Right, no, I know, but do you have one in your hospital, a pharmacy that could administer these special, quote unquote, special?
So yeah, we do have an inpatient pharmacy. Occasionally we have tried to use it to get these medications for the patients. But then we run into coverage issues.
Right,
Usually.
okay. Okay, thank you.
Any other questions for Mr. Heiser?
Yes.
Go ahead, Senator Hooker.
So where do these drugs come from? These special drugs, I mean, are they all compounded in the hospital pharmacy? And you're here to answer that question.
I would actually suggest that Wes.
Right,
So, Wes
Thank you.
McMillan is also here, so why don't you chime in, Wes? Thank you. Mr. McMillan.
Absolutely. So me make sure I get the right question. So where are the medications coming from, Senator Lyons?
Senator Hooker was asked, go ahead.
Yeah.
Okay, I'm sorry.
I'm listening to, you can't have them coming from these mail order houses because of the problems that may transpire, but when a patient is prescribed a particular treatment and we need the white bag to get the medication to that patient, and Senator Hardy asked about small, rural hospitals having pharmacies of their own. Where do the drugs come from? And are there not similar issues for larger institutions?
So the drugs that are payer mandated, white bagged, often come from out of state. So it could come from a pharmacy in Massachusetts or New York, from all over the place, wherever that product is centrally located. So as an example, from CVS, it may come from Boston. It could come from New York City. It could come from Tennessee. So those products are shipped from all over the country to the point of location of that specific provider in a white bagging situation. So they could send that to UVM Medical Center, to the provider clinic, to the pharmacy, to the mailroom, just wherever the drug goes to, as John alluded to. And that's the same regardless of size. So, Porter is the same way, Rutland Regional Medical Center is the same way, is that those medications will come into our general receiving, into our mail rooms and then get redistributed from there. It could come FedEx, UPS, USPS, pretty well from any mechanism of a delivery. These specialty medications could come through from a white bagging standpoint. So hopefully, Senator Hooker, that answers your question.
Yeah, but again, are you subject to the same problems that, the pharmacy, local pharmacy would be subject to, or the medication going to the consumer, to the patient? I'm just trying to figure out what this bill is going to do to alleviate the problem overall and make it safer for the patient.
Oh, absolutely. And I think the bill, for me, it spells out how to ensure product integrity, if you will. So it allows for white bagging and brown bagging to still continue. My personal view is I would love to have it totally eliminated, but I think this mechanism allows for those smaller facilities to still maintain a supply chain if they cannot bring in these expensive medications and have to use the pharmacy benefit. So the mechanisms that are spelled out are really around kind of the supply chain control and tracking of those medications. So it puts into the bill features with respect to temperature tracking, monitoring, and how those medications are sent. So I think it really puts some clarity around just really the supply chain of those medications. So it opens up the ability to maintain that supply chain in-house, to really have true supply chain integrity and pedigree. But if the folks in the clinics, cannot use that mechanism due to the expense of the products, it still allows the ability for those products to be white bagged in. But then it has the control mechanisms to ensure that those products are not tainted and can be used, and you have less of a concern for products that have not been handled in the appropriate condition.
That makes a whole lot of sense. And then I guess I want to know how this intersects again with section 4.
We'll get to that. I think we should move on to Margaret Lagus, and then we'll be able to, we'll have an opportunity to do some markup on the bill another time. But this is some good input. So thank you for being here.
Absolutely.
So why don't you introduce yourself for the record, and we do have your testimony on our webpage.
Yes. For the record, my name is Margaret Lagus.
And just FYI, we are going to stop cleanly at 11:30. But
I am aware. I'm going to try to speak as quickly as possible.
all right.
I'm pretty good at that. For the record, my name is Margaret Lagus, and I represent America's Health Insurance Plans, a national association of health insurance providers. And today I'm going to talk about pharmacy benefit managers as well as specialty pharmacies. Pharmacy benefit managers have been around for decades, but only became widely used when pharmaceutical prices began taking up a significant chunk of every health insurance dollar. The administration of these benefits became too great for individual insurance companies, and they began to look for alternatives to in-house management. PBMs have the ability to purchase drugs on behalf of millions of Americans, giving them bargaining power and providing discounts that are just not possible for individual insurance companies to get. They also keep prices down throughout the supply chain by collecting data that has become integral to understanding how drugs are being used, their efficacy, and the prescribing habits of not only individual doctors, but hospital systems in entire areas of the country. This kind of data would just not be available to individual insurance companies without PBMs, and has shown to be a benefit for all care providers. PBMs would not exist if they did not provide significant value to their customers, who are insurance companies, and through the insurance companies, the pharmaceutical purchasers. If PBMs were not saving insurance companies money, they would have long since reverted to their in-house systems. PBMs through the insurance companies become highly regulated because insurance companies have all of their pricing regulated in Vermont through the Green Mountain Care Board. So if they weren't saving money, they wouldn't be in existence. Nobody likes the person that is requiring a reduction in payments. So they're not popular. You've heard testimony that passing this bill will save money for Vermont's insured population. In looking through research on the few states that have passed some measure of PBM law, and first of all, not a single state has passed the entire breadth of the original bill that was introduced. There's no evidence that passing these laws in and of itself saves any money. Insurance rates have varied over the last several years due to numerous factors that include, but are not limited to, the expansion of Medicaid eligibility and increases in the overall number of insureds in America following the adoption of the ACA. There is no way that requiring a higher payment to pharmacies for processing and handling pharmaceuticals will lower costs. There is no way that allowing more handlers into the specialty pharmacy space will lower costs. The loss of local pharmacies is hard on their customers and the towns in which they are located. But these changes in the marketplace are playing out in many sectors of the economy, including grocery stores, auto parts stores, restaurants, et cetera. This bill will not save small independent pharmacies any more than passing a bill to require food distributors to charge smaller fees to small independent grocers would save them, even if they are a priority in our communities. Healthcare spending is skyrocketing, and pharmaceuticals play a large role in that increase. But just locally, there are other pressures lurking in the near future. Just look at the huge increases that hospitals are asking for in mid-year budget adjustments. It is estimated that they might be looking at significant double-digit increases next year. Being able to hold down prices where possible is of paramount importance. This is a role that PBMs play, and even though that role makes them very unpopular to pharmacies, it is certainly a benefit to Vermont's insured population. Overall, this is an incredibly complicated issue, and it might be one where all of these provisions should be taken a look at by DFR with a Vermont-specific lens, and then come back to the legislature and say, this is where some of these changes might make sense, and this is where some of them might not. Vermont has already passed many bills that affect pharmacy benefit managers, whether it is within the arena of gag clauses or audit reform. We've already restricted the auditing capabilities of PBMs several years ago. And then specifically with regard to specialty pharmacies, I gave to your committee or submitted for the record 10 different pharmaceuticals that come through specialty pharmacies. And if you look at them, the hospital charge is always approximately twice even a physician office charge, and sometimes 3 times as much as a specialty pharmacy charge. So what S242 does would allow more and more of these drugs to be delivered through the hospital, which, as you can see, may very significantly increase the overall cost of these specialty pharmacy drugs. Just to give you one example, Remicade, which is used for patients with Crohn's disease, it's generally a monthly infusion done in an outpatient setting. The average hospital charge was $10,000, a physician office was $5,000, and a pharmacy charge was $4,500. That's a very significant single drug difference. There are some others that are for rheumatoid arthritis where the price difference is the hospital on average was $17,000. The physician office was around $10,000, and the pharmacy was also around $9,000. So that's why we really ask you to be very cautious about passing either of these bills because of, in general, their cost-saving measures of the current practice.
Okay, thank you. So I hear you don't have this testimony that you just gave. We don't have that. If you could send that.
Yes, I will submit it as soon as we're off.
Yeah, okay, that would be helpful. You talked a little bit about how the PBM is saving insurance company dollars, and then the question that we have in this committee, of course, is patient safety and quality for the delivery of those drugs, and that might have longer term savings for a patient. But questions committee. All right, we're good. Wow. Any questions for any of the folks who are here with us this morning? Thank you all. This has been very helpful, and we will go forward going through H353 and S242, looking at the relationship and trying to put some of those things together. So I think that we're going to go off YouTube